Hello.
Just a minute, madam.
Shall I start share screening?
Madam, we are live now. We can start. Hello.
Hello?
Yes, madam, we are live now. You can start.
Good afternoon, everybody. I thank one and all for joining me in this session of learning about first trimester bleeding. And I thank the organizers for giving an opportunity for this. And today we'll talk about a common subject, that is the first trimester bleeding. Everybody is happy the moment she is pregnant. She starts loving getting great to everybody, wants to give sweets to everybody. Whole family is happy. But suddenly she has a drop of blood. And we can see the panic the patient gets on and how the child tries to run to us. It is our duty to take what is the cause, how best we can help her. So today we'll talk about evaluation of the first trimester bleed. Now you know all the causes. They can be, if you see, approximately 1/4 of pregnant women have experienced bleeding in their first trimester, and it can be an implantation bleed, an abortion, an ectopic, vascular mole, or some local causes. It is for our duty to see what is the cause and how best we can help the mother and the baby to be born. If you think it's an abortion, it can be a threatened abortion, inevitable abortion.
Hello.
Yes,
yes, madam. Sorry to interrupt you. In case if you are changing the slides at your end, because here the slides are not getting changed.
not moving.
No, madam.
Can you see now?
No. Now also the slides are not getting changed. So we just just reshare the slides once again.
Okay. Hmm?
Now try changing the slides.
Can you see now?
No, madam. Here now also the slides are not getting changed. Yeah, now the slide is changed. Causes is there. Try changing this abortion slide is there. Diagnostic criteria. Yes.
No?
Yeah. Now the slides are getting changed.
Okay. Sorry for the inconvenience.
No, madam. Sorry for the interrupting you.
We are talking about the causes of first trimester. We all know first trimester is from day 1 of missing period up to 12 weeks. So anybody having a spotting in that period is very much bothered to know whether you want to continue pregnancy, especially. Just imagine a 35 or 36-year-old lady consisting of 10 years married life. She's so happy that she become pregnant and suddenly she stops bleeding. So it is our duty to know what are the causes, how we can evaluate, how well we can
Hello. Hello. Yes, madam. Are you there? Hello.
Hello? Hello?
Yes, madam. Yes, yes.
Can you hear me? No, that's better.
Yeah.
Sorry, there's a problem with my network.
No problem, madam. It's okay. It's okay. We can start again the sharing of your screen.
Can you see now? Hello? Can you see?
Yes, madam. Your slides are visible. Yes, slides are visible.
So the diagnostic criteria is when
I'm just requesting you turn on your camera.
can you see? When HCG reaches levels of 2000 for international units, your sound. This sac is greater than 10 millimeters in diameter, you must be able to yoke sac. And if you are seeing the crown drum length,
Madam, sorry to interrupt you. Can you please turn on your camera?
so when your crown length is, sorry, can you see?
No, ma'am, your camera is not on. You need to turn on your camera.
Can you see now?
Yes, yes.
Okay.
Yes, yes, madam. You can continue.
So there are few diagnostic criteria which you must fulfill to say this pregnancy is okay or not. So when you think of that, when you see the HCG levels are 1500 to 2800 units, you must be able to gestational sac at least in the transvaginal scan. And when the sac is more than 10 millimeters diameter, yolk sac must be present. And when CRL, that is crown drum length, is greater than 5, that you remember the 2, 10, and 5. If it is CRL is 5, a live embryo must exhibit cardiac activity. If any of these things are not there, you are regarded, you should say, this pregnancy is not going to grow up in an abortion or a missed abortion. A normal pregnancy, a beta subunit of human gonadotropin levels increases 80% every 48 hours. That is called doubling. So if it is growing normally, if you see it as 4,000 today, by day after birth, it should become 8,000. So these are the 4 things that should always be there for a normal healthy pregnancy. So absence of any of these discriminatory findings is consistent with early pregnancy failure. So, but it does not, of course, distinguish between ectopic pregnancy and failed intrauterine pregnancy. The presence of an adnexal mass or free fluid present may be suspicion of ectopic pregnancy. So you have to be careful when you don't see any cestal sac within the uterine cavity. At the same time, you see an adnexal mass and have fluid collection, Dowser Douglas. At the same time, patient gives a complaints of missed period and pain abdomen or syncopal attack. You must be very alert to think it could be a case of ectopic pregnancy. See, you see figures here. This is a yolk sac with gestational sac, and at 5 to 6 weeks menstrual weeks, and this is the first sonograph finding you must say to say it is a positive intrauterine pregnancy. Here the embryo is visible as a fetal pole adjacent to yolk sac is there. Cardiac activity is often visible at this time, especially in transvaginal scan. In transvaginal scan, you see earlier than the transabdominal scan. Here it is a normal healthy pregnancy, but there is a small subchorionic hemorrhage is there. This is as a sonolucent area adjacent gestation sac, which contains an embryo and a yolk sac. So both embryo and yolk sac are there, but still there is a subchorionic hemorrhage is there. These patients should be observed, and usually they go 80% of them grow normally, and this subchorionic hemorrhage disappears in future few legs. And here, if you see, as I told you, the crown rump length, when it is more than 5, you should be able to see the fetal heart. The most accurate way to date a pregnancy, and this 10.5 pregnancy measures 38 millimeters. These are the few norms which you should follow when you're doing a scan, when you're diagnosing a case of pregnancy. Now, coming to the definitions, an embryonic pregnancy, there is no embryo. So, presence of gestational sac.
Sorry to interrupt you once again, but now also the slides are not changing. Currently, I am able to see slide number 4 only on my screen.
No. Slides move out later. Now they are moving?
No, madam. The diagnostic criteria slide only I am able to see.
Stop sharing. Immediately out.
Try changing the slides.
Shall I send you the slides?
Yes, madam. You can share the slides with me. I will just send my email ID to you.
I see once.
Yeah. Try changing the slides.
Are they moving?
No, madam. Just click on slideshow. Just try to click on slideshow.
I keep it as slideshow only now. Slow starting. Oh, is it moving?
Yeah. Now I can see the definition slide.
Yes, okay. So, an embryonic pregnancy is presence of gestational sac larger than 80 millimeters without evidence of embryonic tissue. This term is preferable to older and less accurate term of blighted ovum. So, we call it an embryonic pregnancy. Embryonic demise is an embryo larger than 5 millimeters without cardiac activity. This replaces the term missed abortion. So, we no more call it as a missed abortion. We call it an embryonic demise. And recurrent pregnancy loss is more than 2 consecutive pregnancy losses according to ACOG, and more than 3 according to the RCOG is called a recurrent pregnancy loss. Previously, we used to call it habitual abortion. That also we call it as a recurrent pregnancy loss. Spontaneous abortion is spontaneous loss of pregnancy before 20 weeks of pregnancy. So types of abortions can be threatened abortion, bleeding before 20-week gestation in the presence of a live embryo. Complete abortion is complete passage of all products. Incomplete abortion occurs when some, but not all the product consumption are passed out. Inevitable abortion, bleeding in the presence of dilated cervix, indicates that passage of the concept is unavoidable. Septic abortion, incomplete abortion associated with ascending infection of the endometrium, parametrium, adnexa, and peritoneum. Subchorionic hemorrhage is sonographic finding where blood between the chorion and the uterine wall usually settles out. Setting of vaginal bleeding may be there, but when you observe for some time, usually this gets absorbed and the pregnancy will grow normally. And vanishing twin is one more commonly seen. First they do a scan, they say you are having triplets. After 1 week, they say you are only having 2. And at 20 weeks, you see only 1 fetus. So this disappearing of the one twin in multiple pregnancy is called vanishing twin. And the other cause of bleeding is ectopic pregnancy. Pregnancy outside uterine cavity, most commonly the fallopian tube, but may occur in the broad ligament, ovaries, cervix, or in the scar of the previous LSCA scar, elsewhere in the abdomen also. That is called secondary abdominal pregnancy. So this is all pregnancy when you see outside uterine cavity, you call it as ectopic pregnancy. And third, more dreadful is the gestational trophoblastic tumor, or otherwise you call it a hydatiform mole. This can be complete or partial. That is, the pregnancy doesn't form as the baby is not formed, but the male factor, that is a paternal form of the chromosomes, will grow into an abnormal cells, and that is the molar pregnancy. It is complete mole or partial mole. And partial mole, there may be molar tissue along with an incomplete fetus. And the third thing you have to feel is heterotropic pregnancy. That is, simultaneously there is intrauterine pregnancy and ectopic pregnancy. This is a tricky thing. Sometimes we see it is an ectopic pregnancy. We think of doing medical management like methotrexate. And when you do a scan after 4 days, you see your dismay. You see an intrauterine sac also. So though you are destroying both the, especially you feel bad when it is a very precious pregnancy. So these things are common things which you have to see. Apart from this, there can be a local polyp, a tear, an injury, or it can be a foreign body which is causing bleeding in the during the first trimester. It's a coincidental cause. So you have to evaluate the patient, take history properly, as when she is married or not, what is the amenorrhea she is having, and whether she took any treatment, the spontaneous pregnancy or not. Before having bleeding, did she have any injury or pain, or the amount of bleeding, when there is less bleeding or very heavy bleeding, or is there any trauma, will she take any drugs for abortion? All these things you have to evaluate to know what could be the cause in the history itself. I will say a spontaneous pregnancy or an IVF pregnancy, because these IVF pregnancies are more prone for missed abortions and more prone for ectopics also. So you have to be very careful to take the history. So early diagnosed pregnancy loss can be ultrasound findings at diagnostic and early pregnancy loss. As I told you, a mean gestational sac diameter 25 millimeters or greater, crown length of more than 7 millimeters or more, with an embryo and no fetal cardiac activity, it is a early pregnancy loss. So treatment options, what do you have? So when other things are all normal, you are very sure about the pregnancy history, and you have these things on the scan. She may say, no, I had only period of only 4 weeks amenorrhea. But when you see a CRL of 7 millimeters, definitely it is more than that. And there is no fetal heart. So you can definitely say, yes, it is going to be early pregnancy loss. Treatment is, you can wait and watch. Most of the times, especially if it's a very precious pregnancy, they don't want you to say, yeah, she has an abortion, she wants to wait. So if she is hemodynamically stable, not having much of bleeding, you can wait and watch. You can get a Korean beta ECG done and wait for 48 hours and rescan and confirm, because it is very traumatizing to the patient to say this, your pregnancy is not good, you're going to terminate it. So you can have an expectant management, or if you're sure that is a pregnancy is not there, you can help her out with medical management by giving mifepristone or misoprostol. And if that is more than 12 weeks, then or 10 weeks, and she is not willing for medical management, can go for a suction evacuation. As I told you, what are all the causes for first trimester abortion? It can be endocrine, like luteal phase deficiency, hypothyroidism, or uncontrolled diabetes. Genetic aneuploidy accounts for about half of the spontaneous pregnancy losses in the first trimester. Immunological, like antiphospholipid syndrome or lupus, and infections like chlamydia, gonorrhea, herpes, listeria, mycoplasma. Usually they are caused in the late first trimester or early second trimester abortions. Occupational chemical exposure, radiation exposure, and you train, they're like it can be septum, subsequent uterus, and adelphus, or trauma, and of all things may be unknown cause for the abortions. How do you manage? Evidence does not support routine use of antibiotics in all women with infant abortions. Unless you are going to interfere, do a suction evacuation, there is no role for antibiotics. But expected and surgical management miscarriage are equally effective. Patient's preference should be play a dominant role in choosing treatment. Patient comes from far place and she doesn't want to stay for a long time. We expect a treatment to give misoprostol and ask her to come back for checkup after 48 hours, do a scan, again repeated. The patient coming from far off place or cannot attend the doctor again and again, doesn't like it or not advisable. For such patients, you can do section evacuation as single time procedure and send it. But all said and done, section evacuation is a invasive procedure. So there can all the complications along with that are all expected complications are there. So we usually try to avoid an invasive procedure. Medical management is always preferred. So the patient has an income abortion, non-surgical treatments have a high likelihood of success. The patient has an embryonic demise or an embryonic pregnancy, misoprostol or surgical treatment is more effective than expected management. Second abortion, again, expected management, bed rest does not improve outcomes. We see patients sticking onto the bed for weeks together for threatened abortion. It's not advisable because when patient is on the bed for a long time, as you know, pregnancy itself is a hypercoagulable stage. So patient can develop DVT. So some amount of walking is expected and advisable than to have complete 24/7 bed rest. There is insufficient evidence of use of progestins, but we all use it. And HCG discriminatory role is the beta HCG level above which the intrauterine pregnancy should be visible on transvaginal sonography. Failure to detect an intrauterine pregnancy, combined BCH levels higher than described level, as I told you, would be a cause of ectopic pregnancy. Again, how do you manage it? Vaginal misoprostol safer, more effective. After first trimester pregnancy loss, patients who are Rh negative should receive 50 micrograms of anti-D immunoglobulin. But as I told you, it is a very saddening thing. Patient may get psychologically total upset. So you have to understand their grief, be sympathetic with them, reassure them that everything is okay. Within 2 or 3 months, they can again conceive. And if they are elderly, if they see around 30, more than 35, and there's a prolonged period of infertility is there, you have to evaluate the patient, not just simply reassure them. Further evaluation, especially for RPL, is very important. Incidence, ectopic is 1 to 2% and accounts 6% of all maternal deaths. Leading cause of pregnancy-related death in first trimester. Women present with abdominal pain, vaginal bleeding, syncope, hypertension, and you perform pregnancy is positive. These are the people actually who are lucky who come with abdominal pain and vaginal bleeding and syncope. That is, these are people who are having a ruptured or near rupture ectopic pregnancy. Those are the people who go into a chronic ectopic, who are missed, and they come up with a PID and ultimately end up in infertility. These are usually who are missed in the diagnosis. Prompt ultrasound evaluation is the key for diagnosing ectopic pregnancy. Equivocal ultrasound results, quantity beta subunit HCG is there. Then you established criteria should be used to determine the treatment option for ectopic pregnancy. As I told you before, gestational sac should be there, yolk sac should be there, fetal heart should be there. They're all not there. Then you think of ectopic. Again, if the low HCG is there, patient is very stable, you expect management can be given. But medical management methotrexate is used always even when patients are stable, hemodynamically stable. But if the patient is not even stable or she's not fit for methotrexate, you go for surgical intervention, then either laparoscopy or laparotomy, you take out the tube. So current intrauterine device patient is using, she can be a history of ectopic pregnancy previously, pelvic lymph disease, history of tubal surgery, especially decolonizations, or patient had a tubectomy before, now she is having a pregnancy positive, and in vitro fertilizations, infertility, long period infertility, patients who are smokers are more prone for ectopic pregnancy. So expected management, I told you, is evidence of tubal rupture, minimal pain or bleeding, no tubal rupture, patient reliable for follow-up, she can start, she can be admitted, she can come for checkup, and the beta levels are not more than 1000 per ml, and they are decreasing. These are the patients whom you can give expert management. That means you don't give anything, just to observe them. And ectopic or adnexal mass should be less than 3 centimeters. No heartbeat is seen in the adnexal mass. For these patients, you can give expected management. That means you don't do anything, just observe them soon, what is happening. Medical management, stable vital signs, a few symptoms are there. No medical content like for methotrexate. It should be an unruptured ectopic. Cardiac activity should not be there. Ectopic mass should be less than 3.5 centimeters or less, and starting beta level should be less than 5 international units. If anything of this more than it is there, she will go for a surgical management. In medical management, you can give single dose of methotrexate at the rate of 1 milligram per kg body weight, and single intramuscular injection is given. Follow-up is beta-HCG on 4th and 7th post-treatment days, then weekly until undetectable, then usually takes several weeks. The beta-HCG will come down within 50% within 4 to 7 days, but the mass takes a longer time to disappear. So don't go by ultrasound to see the resolving of the adnexal mass. It should be the beta-HCG follow-up. It should be taken for the treatment, the successful treatment of the ectopic. Expected beta-HCG change, initial slight increase, then 15% decrease between days 4 and 7. If not, repeat the dosage or move to surgery. But when you are taking any patient of medical management, should always counsel them and say, yes, we are trying medical management, but any time if you deteriorate, if it doesn't become successful, you may have to go for surgical management. A consent, written consent is always needed before you start a medical management. Otherwise, in these days of controversy, you may be sued for unnecessary. So always inform the patient, what we're trying for your good. If it's possible, we'll do it. Otherwise, you must be given prior consent itself, prior legal consent for management of surgical districts. So prompt availability of surgery, if patient does not respond to treatment, is the sheet anchor. So surgical management, unstable vital signs or signs of hemoperitonum, uncertain diagnosis, advanced ectopic pregnancy, and patient unreliable follow-up or contraindication methotrexate. There's no follow-up. In smaller setups where repeated scans and beta-HCGs are not possible, better go for surgical management. And I told you the last one is the gestational trophic tumor. So we are talked about the pregnancy and the and its failure. When the pregnancy comes out of the is for ectopic, and the third is the gestational trophic hydatiform mole. In abnormal pregnancy characterized by varying degrees of trophoblastic proliferation, both cytotrophlast and cytotrophlast. Vesicular swelling of the placental villi associated with absent abnormal fetus. Two types of hydatiform are there. One is complete, one is incomplete. That is partial mole, based on both morphological and cytological criteria. This is a typical ultrasound screen image when you see a case of vesicular mole. There is no fetus. This is called snowstorm appearance. It is actually you can say a spotter in the exams to say that it is a case of vesicular mole. In this, if you see a small part of it like this, and another part you see a small fetus, that becomes an incomplete mole. So what are the epidemiological risk factors? Age can be less than 20, there is teenage pregnancy, or it can be an elderly patient more than 40. Prior complete mole, history of spontaneous abortion, dietary deficiencies, induction of ovulation is there, OC pills, history of menstrual irregularities, and of course, ethnicity. And if we hydatiform, if you see, complete mole is diploid, absent of fetus or embryo. Partial mole is triploid. There can be a small embryo or fetus along with the vascular part. And clinical factor, vaginal bleeding, large for dates of uterine, bilateral thicoid and cyst may be there. Medical complications may be like thyroid or diabetes can be there. HCG is often more than 100,000 international units. Whereas partial mole, pre-Janssen diagnosis usually incomplete or missed abortion. Medical complications are rare, and HCG is not more than 100,000 units. 5% of post-molar pregnancies could be there. So these are all the genetic chromosomal structure we can get in a vesicular mole. It can be monospermic, dispermic, diploid, biparental only, or they can be dispermic. Both the sperms are there, no maternal component is there. She may present with simple vaginal bleeding or pain abdomen at 6 to 16 weeks of gestation. But nowadays, with good ultrasound available every nook and corner of the country, we are able to diagnose them at an early stage. There were days when we were young, we saw 36 weeks and 38 weeks full term. Patient came with almost collapsed with bleeding, with gestational trophic tumors. We don't see such big tumors now. We are able to diagnose them mostly at 6 to 7 because dating scans are done everywhere and you can pick them up very early. Uterine enlargement extended more than the period of gestation, hyperemesis, toxemia, as a result of widespread scan, accurate tests done early, we are able to diagnose them early. And bilateral thecal uterine cysts, enlargement of the ovaries occurs approximately 15% of cases, and usually when left alone, once it is evacuated, because the high CG levels come down, these thecal uterine cysts also come down, doesn't need any surgery. Diagnosis, as I told you, is ultrasonography. SCG is a disease-specific marker. Identified moles are commonly associated with markedly elevated SCG levels above the normal pregnancy. Despite earlier diagnosis of complete moles resulting in fewer complications, but the sample reduction in the incidence has not come down. We are able to only diagnose them early and treat them early with less complications, but we are not able to tackle the number of cases that are occurring. But we are not seeing bad cases nowadays. But these cases, the only thing what we are feared about these cases, some of them, a percentage of them can go into malignancy, that is choriocarcinoma. So the only problem, only tension we have about the vesicular mole is we cannot say which is going to become a vesicular mole, which is going to end up in a choriocarcinoma. So there are some criteria about the age, when the pregnancy is followed, when the vesicular mole is following a complete pregnancy, what is the age gap between the previous pregnancy and this vesicular mole? If the patient had previously vesicular mole to have a recurrent vesicular mole, the blood group, these are some of the criteria by which give a score. This is a high score or less score. When the high score is high, these are the patients who are to be followed very closely because they are the patients who can develop into choriocarcinoma. So you have to evaluate medical complications, correct them, like anemia, preeclampsia, hyperthyroidism, basic laboratory tests like VBP, blood grouping, metabolic panel, TSS, CE, X-ray chest, and if it is more than 6 weeks gestation, ECG, coagulation profile are all indicated. Once the patient is determined to be hemodynamic stable, most appropriate method of molar evacuation should be decided upon. Surgical management is the thing. Here, suction evacuation method is method of choice for evacuating antiform mole. Independent uterine size, the patients who wish to maintain their fertility. Blood and blood product should be available. Patients who are RH negative should receive anti-D immunoglobulin at the time of evacuation, as the RH factor is expressed in trophoblastic cells. Because with normal abortion or a pregnancy, we do the cord blood and do whether it is having positive or negative. Here you don't have the chance. So you give prophylactic anti-D for all these patients of RH negative mothers for having this vesicular mole. Hysterectomy in high-risk patients like elderly, more than 40, great-grand multi, and who are having very high levels. These are the patients who may end up in this choriocarcinoma. So these patients are at the risk of this malignancy. So they may be advised a hysterectomy. But if it is a case of choriocarcinoma, just doing hysterectomy, you're not totally free. These patients still need follow-up because it can be already spread by the time you do the surgery. So medical induction of labor, hysterectomy are not recommended. These measures increase the maternal morbidity and mortality. There is lots of blood loss. Incomplete evacuation may require curettage, and the requirement of cesarean delivery in subsequent pregnancy will be dangerous because they can have adherent placenta. And they also increase neoplastic dissemination, development of post-molar gestational tropic neoplasm during requiring chemotherapy. So at the time of immediate after evacuation of molar pregnancy, you can give prophylactic chemotherapy, reduce incidence of post-molar GTM, use of prophylactic chemotherapy only in high-risk patients. That is more than 40 years, when HCG is more than 10,000, 100,000 units, and excess uterine enlargement, fecal is more than 6 centimeters, medical complications, when adequate HCG follow-up is unavailable, unreliable, and especially all patients who are followed serially beta HCG testing after molar evacuation are found to have persistent GTN can be given appropriate chemotherapy. Recently, I had one patient who had conceived after IVF pregnancy, but as I told you, the discriminating criteria, when we did the scan, because it was a IVF pregnancy, we know definitely when the embryo transfer was done, but the whole uterus was showing a thickened endometrium with all fluffy areas. So an ultrasound scan itself, the diagnostic test, probably a vascular mole. We did a suction evacuation, sent it for histopathology, and we thought everything was okay. But she came back to us after 4 weeks with then spotting. We did a scan again, the endometrium was thick, and her uterus level slowly started increasing to 8,000, 12,000, and we put her on chemotherapy. And I'm telling you, we are really surprised. She's a young patient of 28 years, no other comorbidities. It's nearly 3 months. She has received already 3 courses of chemotherapy. Now she is on the 4th cycle. Now we are giving 2 doses. Still, the beta levels are around 4,000 to 6,000, not touching normal. So we just can't just evacuate a patient and leave her alone. We have to follow her up. If the beta levels are falling and reaching by 50% within the first or second cycle and reaching zone 0, we have to continue the thing and follow up them for 6 months to 1 year also. So when the patient comes to you with the first trimester bleed, menstrual history is very important. Physical examination should be done. Ultrasound is a sheet anchor to diagnose it. Serum beta HCG levels will clinch the diagnosis. Medical or surgical management has to be discussed with the patient, and safe management is what that is needed. Thank you for listening, and I apologize for the network problem I had, and the problem sharing the slides was a difficulty. Thank you.
Yes, hello.
Yes.
Yeah, madam. There are some questions also now. So I'll be posting the one by one the questions.
Sure.
I posted the first question in the chat.
What problems with the placenta can cause bleeding during pregnancy? See, the placenta, first thing I told you, if she's having a subchorionic hemorrhage is there, that can resolve when you observe for some time, or that can spread, leading to placental separation, further bleeding, and ending up in a spontaneous abortion. This problem actually comes when she is a case of RS negative. So the thing is whether to give anti-D or not, and how many times you give anti-D in an RS negative in the within a, see, she had one bleed, you give an injection. After 6 weeks again she comes with the bleed. You have to repeat it. Yes, you may have to. See, every time you cannot do clear test. So better is to give under 50. But by giving again you get the beta, I mean, direct Coombs test or indirect Coombs again positive. So there are tricky things which happen. And if the placenta is low lying, say it's a case of previous section, and we had one more patient recently, she has this placenta was onto the cervical region at the level of the scar, and it ended up in a scar pregnancy. So we had to do a hysterectomy. She was a young patient. She was actually treated outside, came to us very late. So this placenta was totally adherent there. We had to do almost a excision of the scar and take out the placenta. And the patient was very moribund, and so to our luck and to her luck, she picked up. So the placenta can get adherent, and she can also have placenta accreta if repeated separation bleeding occur, or she can have a to get a more and more of blood supply, it can recede down and become placenta previa also. And not only that, this patient having bleeding again, the placenta is not getting proper and blood supply, the anoxia is there. So these patients are prone for future preeclampsia, IUGR, and IUD of the fetus.
Madam, I also posted the second question. Hello.
Yes. Anything else?
Yes, madam. I have posted the second question also in the chat.
Another question.
Yeah.
What problems can cause bleeding later in pregnancy?
Yes, madam.
As I told you, these are the patients who are to be guarded. And these patients usually, we also do a uterine artery Doppler for these patients, and these patients with their BVH cases and having repeat bleeding, and the patient is having a case of recurrent pregnancy loss, there can be uterine artery Doppler, and these patients, when you follow up slowly, they can be umbilical artery Doppler also is showing resistance. And these patients, we put them on. Again, here there is a tricky thing. She is having a bleeding, whether they put them on aspirin or not. That's if you put aspirin, the bleeding may go up. If you don't put aspirin, the blood cell supply, blood supply may be hampered. So you have to do again, weigh between the things, evaluate the patient properly, and at the same time, you have to see whether you are going to do the PTNR test. And if she is a case of, say, APLA positive, you may have to do this thing, not only APLA, this aspirin, but also the low molecular heparin, and follow them up. If they are also showing increased resistance of blood flow in the umbilical and uterine arteries in the later weeks of pregnancy, nowadays we are also using sildenafil locally, vaginally, so that the blood supply to the placenta increases by vascular relaxation of the uterine vessels. So umbilical artery resistance also will decrease when we give local sildenafil. Actually, we are doing a study for that. We are getting very good response in patients of IUGR, in patients of low, increased resistance, and also in case of oligohydramnios by using sildenafil for 25 milligrams 8 hourly vaginally. Within 2 weeks, we are seeing good response. So all these patients show that they are at high risk and they need close follow-up, whether this is only a local problem that has a temporary problem that has come and it recovered, or it's going to have a permanent damage to the placenta and subsequent to the fetus. So this is a warning sign to show that they need to be followed up carefully till the patient at least reaches 37 weeks. No, the bleeding during pregnancy always does not mean there is a problem. First, as I told you, had to evaluate what is the cause. First, rule out the local cause. So many times, patient was coming to me last year, repeated bleeding, and she refused her examination. No, I'm having bleeding. By doing an examination, probably I will lose the baby. So actually, we convinced her, we counseled her, and then when we put a speculum, there was a polyp at the cervix, which is bleeding again and again. So that such things, small things can be treated. And as I told you, so the subchorionic hemorrhage, usually by observing them for a few weeks, usually stops on its own. And though the textbooks say they do not need any extra progesterone, we are all not that comfortable. We put them on progesterone and minimal bed rest. And with that, usually most of the time they recover well.
Yes, madam, we are done with all the questions. Thank you, madam, for your valuable time and sharing important insights on the topic.
I'm also sorry for the slides.
No problem, ma'am. It's okay. It's a technical thing. It happens. No problem, madam. It's okay. Yeah.
Thank you so much.
Okay, madam. Thank you.
All my people who joined us.
Yeah. Yes, madam. Yes. 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 Madam.
Thank you.
Yes.